You guys have a lecture after this?
Just McNeil.
I'm gonna keep it 3 p.m. Okay. Metacarpal fracture. Let's start with PowerPoint. So these are very common fractures for hand. Obviously, you can think there's a broad array and different types and angles and all the different metacarpal bones you have in your hand, and they all kind of have their own little nuances to them as well. What we're going to talk about, we're going to discuss just a few variants: boxers, Benets, and Rolandos, and all these dead guy names that we have in there too. And boxers not dead guy names, boxer fracture. Just those are used so that I don't have to type out a huge long fracture description of what we're discussing. But other than collies and boxers, I think it'd be safe that when describing a fracture or a type of fracture to any other person, just describe the fracture itself and don't try to use the specific names. Because you got to remember who you're talking to, who your audience is. They may not know what a Galeazzi fracture is. I mean, I would hope that an orthopedist would know, obviously, but if you're trying to describe it to anybody else, just describe the fracture itself. Let them use these dead guys. Boxer's fracture, so it's going to be metacarpal neck fracture, the 4th or the 5th ray. Obviously, they call it a boxer's fracture because it's associated with punching something, even though most fractures of the hands of boxers have nothing to do with fractures of the 4th or 5th ray. So that's a funny little tidbit of information right there. Most common fractures in the hands of boxers are not boxers' fractures. But you do see this injury with, your drunk 20-year-old super testosterone male, his girlfriend just broke up, and he's bam, he just hits the wall, and he breaks his hand, and you're just like, grow up, dude. So you see that a lot, especially out in rural Oklahoma when that's like half your population out there. So metacarpal neck fracture, 4th and 5th ray, boxer's fracture. The treatment is going to be ORIF on this one. You're going to see, so this is just a single view, it looks like AP view of the hand here. It's difficult to say, but from what looked like, there's obviously some shortening of this fracture right here, and I would say when you get the lateral, there's going to be quite a bit of displacement and, if not angulation on this. So shortening is going to be, I don't know if we discussed that in our fracture morphology when we first talked about it. Shortening is going to be when you have two bony segments that normally align like this, then overlap each other, and that segment becomes shorter. So we just call it shortening. That's what's happening right here. So you can see how the elongation of this this ray here, the metacarpal ray, is now shortened because the fracture segments are overlapping or angulated or whatever. It's difficult to say because it may look like this or it may look like this, but on that image you can't really say. That's why you need multiple images to get your depth. So Benet's fracture, Rolando's fracture, those all have to do with the thumb. I'm not going to talk about those a whole lot. It's in your notes page if you want to read more about it. Treatment, again, is going to be splinting above and below the fracture site, and then over-induction internal fixation. Sometimes the boxer's fracture, if there's not a lot of displacement, rotation, or angulation on there, you can get away with doing a splint on there. Does anybody know what type of splint needs to go on these? Maybe in the notes page. Is it in the notes page? Surely. Okay.
It just says splint.
It just says splint.
We'll
Okay.
splint above and below.
Ulnar gutter splint is gonna be the one you want on this one. And it's characteristic, I always have a picture of it. Just Google ulnar gutter splint and you'll see the type of splint. It's a characteristic type of splint that's gonna go on the outside as these two fingers bent in kind of a mild flexion here. And that helps stabilize these fracture segments. So ulnar gutter splint is gonna be Foxter's fractures. Those two should equal each other, right? Okay. So, any questions over metacarpal? I mean, that's pretty quick, but I mean, there's 1,000-page textbooks over fractures and treatment of the hand. So, I mean, it's difficult to go over every single nuanced different fracture. We hit on some of the more common ones. Ultimately, fracture care from primary care, urgent care, emergency medicine is going to be splinting, referred to ortho. And then ortho, hand fractures. Hand ortho is a pretty specific specialty of orthopedics. So if you find yourself practicing, and then you're obviously going to become very well versed in all the different hand fracture and orthopedic injuries. Phalangeal fractures, so more common than metacarpal fractures. Keys to stabilize the joint above and below the fracture site. You use static finger guards, buddy taping, referral to hand surgeon if needed. And that's just for phalangeal fractures. Now there's going to be, 3 different bones in each of the phalange. You can have fractures of the proximal shaft and distal aspects of each one of those bones. You also need to make sure that you're doing your range of motion, see if there's any tendon injury, things like that. But for the most part, they're pretty simple. Okay, thumb ligamentous injury. Thumb, UCL, ulnar collateral injury, also called gamekeeper's thumb or skier's thumb. It's going to be forced abduction and hyperextension of the metacarpal phalangeal joint at that thumb. Skier's thumb, it's called that because when you're skiing, you have your ski poles and you have your wrist straps tied around there. Pole gets stuck in the ground, you continue to go forward, the wrist strap grabs along your thumb and pulls it backwards. Gamekeeper's thumb, I think it's called that because I guess gamekeepers used to get it as they broke the necks of chickens. You can grab them around the neck and do one of these things, flick it with it. You guess if you repeatedly are breaking the necks of poultry, you're gonna get, I don't think people do that much anymore, so skier's thumb I think is more obvious. Those are the 2 names that you'll see associated with it. Hopefully most of the times on testing and boards and stuff like that, they may call it that, but then they'll describe the ulnar collateral ligament to you. But the forced abduction and the hyperextension of the MCP joint is the common. I actually had that happen to me. I was diving out of a softball in the outfield, landed on my thumb, and got ripped backwards. Basically, all you do is just put a pin in it. So examination, you're going to have tenderness of the MCP joint. Valgus stress testing shows the ulnar collateral instability. So normally when you have your thumb, it should, stop right here. But if you have your tendon rupture, there's nothing to stop it. It kind of goes all the way down. Treatment, surgical pin, screw, anchor, thumb spica, followed by physical therapy. So UCL tear. So here we're going to talk about all the kind of weird finger tendon injuries, extensor tendon injury, mallet finger. It's the most common injury to the finger. Damage is from terminal slit of the extensor tendon at the DIP from a direct blow to the tip of the finger. Examination is going to be inability to fully extend the DIP. Obviously, we need to x-ray these things for fractures, so it's going to be it's kind of difficult to reproduce. You're going to have this like little downward flexion. I think I've got a picture of it. Non-surgical, so you can do full-time DIP splinting with extension and hyperextension for 6 weeks, followed by part-time splinting for 4 to 6 weeks. So you just kind of have it, splinted in the opposite direction. And then for complete tendon lacerations, you can have surgery to have it repaired. So there is kind of, so you can see the extensor tendon rupture here. And you can see kind of how the mechanism would be just some kind of force you get jammed up with a football or a basketball or baseball, anything just to forcefully flex that finger there. Here's some mallet finger splints. That's the kind of splinting that you would do. Okay, Buchner deformity, so flexion deformity of the proximal phalangeal joint with hyperextension of the DIP. Examination can be limited extension of the PIP and the DIP. DIPs can be held in flexion. Treatment again is going to be splint with full extension for 6 weeks. Here's your Buchner deformity. Kind of the same thing, except it's a different joint that's involved. All right. So you can see how, I mean, the nice thing about, I'm going to try to not go off on a tangent so much here, but the nice thing about going to PA school, what I truly enjoyed about the training that we received here, is that you get that basics in the basic sciences, and in this instance, anatomy, that you don't have to just depend on rogue memorization of different injuries. If you know the anatomy of the area that's involved, you can kind of work backwards and figure out exactly what's going on. So this person's having difficulty extending from the PIP joint right there. You know the anatomy of the tendons and the tendon sheaths and how they cross, and exactly you can figure out where that injury is based on your knowledge previous of what's going on, and not that you're just rogue memorizing these different things. And I think that that separates us from a lot of the other mid-level positions out there, is the training in the basic sciences. So don't forget that some of this stuff is still important. Jersey finger, so this is going to be rupture of the flexure digitorum profundus. This is going to be occurs with forceful hyperextension of the DIP joint. Jersey finger is going to be typically associated with somebody trying to tackle a football player. They grab their jersey and then that football player rips it away, so you have that forceful hyperextension. Again, treatment, splinting with aluminum finger guard splint, surgical repair if there's damage to the ligament. You can see here FDP, flexor digitorum profundus. You can see where that tendon is ruptured and how it kind of starts to slowly slide back to all right, any questions over any of those? Pretty simple. Synovial tendinostenovitis, so this is also called trigger finger. It's caused by disparity of the flexor tendons and surrounding pulley systems, A1 pulley over the MCP joint. You guys may not be familiar with A1, A2 pulleys. Look them up. It's not that complicated. I wasn't familiar with it until I started rotating with one of the persons that did this stuff a lot. Flexor tendon catches and gets stuck on one of those pulleys. It's going to be painless catching of one or more fingers during flexion. Sometimes causes the finger to stay in flexion and needs passive manipulation to get it back into extension. So you can kind of see how this little nodule on the tendon sheath gets caught in this A1 pulley here, and how you can get it at flexion, but then it gets caught, and so you can't extend it back out. You'll see these people just kind of like this a lot of times, and you'll feel a palpable knot in there. So again, this is another image of the pulley. I thought I had a picture of it in there. You'll feel a palpable knot within their hand of that nodule getting caught in that tendon sheath. And they obviously call it trigger finger because it looks like somebody's pulling a trigger, but they can't get it to go back out. And I've seen people where it's so bad that, I mean, you can't, that whole passive extension to get it pulled back out, you can't, it's stuck like that. Initial treatment, so splinting, activity restriction, and said steroid injections into the sheath to try to get the inflammation down. And there's obviously varying degrees on a continuum of how bad that is, how big the nodule is, how much it gets stuck, how hard it is to pull it back out. Surgical therapy after failing conservative treatment. So Quervain's tendinopathitis, this is tendinopathy that affects the adductor pollicis longus and extensor pollicis brevis tendons. Not really well understood, idiopathic versus overuse. I think it's tend to be more of an overuse injury. You see it a lot in teenage girls that are just texting way too damn much. You know, they're sitting there moving this thumb and they get this tendon inflammation along here, or any kind of overuse injury that activates that tendon itself. Treatment's basic ortho care, splinting, NSAIDs, steroid injections into the sheath. You do Finkelstein's test. Finkelstein's test is basically just grabbing your thumb here, put it under, within your hand, and then you kind of, I guess, flex your wrist down. You can do, if you all kind of do that, you can feel it pull along that adductor tendon there, and that's a positive test if there it hurts right there. It's the inflammation all along that tendon sheath. That's called Finkelstein's test. Grab your thumb here, angling the wrist down towards the floor. And, you know, it gets a little tight just in me,
Yeah.
but in somebody that has de Quervain's, I mean, just doing that, yeah, you know, they don't want to do it. And sometimes on physical examination, you can see that that area is swollen and tender, and even just palpating it feels hot too. Dupuytren's contractures, this is a progressive fibrosis of the palmar fascia. It's benign, slow disease, mostly 50-year-old white guys. Progressive loss is extension affecting the 4th and 5th digits. Treatments, palmar fasciotomy, it's a very difficult surgery. So you can see this palmar fascia here on these 3rd and 4th digits become very thickened in contraction. So these people will be constantly like this, and they won't be able to extend their hand, and it slowly progresses to get worse. This is a pretty tough surgery. So here you can see that palpable cord in this palmar aponeurosis here is just really contractured and tight. And that guy's finger there is just completely stuck like that. I mean, it's not one of those caught on a tendon sheath type things. It's, it's not going anywhere. That type of surgery is, that picture of the surgery, is not fun. I mean, you got to do these big S incisions on the hand and try to, longitudinally slice that fascia and try to get it to loosen up, and it's not a very fun thing. What's the other one I wanted to say about Dupuytren's contracture? Sometimes, Dupuytren's contracture is sometimes associated with a thing called Peyronie's disease. Have you guys had GU yet? Mm-hmm. Yeah, okay. So sometimes that may come up on tests and board examinations about what concomitant disease process. Dupuytren's contracture and Peyronie's disease are sometimes associated with each other. All right, so now these aren't necessarily injuries, traumatic sometimes, but now we go into a little bit more other aspects. Hand infections, human animal bites, you'll see that a lot. Somebody, bit somebody on the hand, bit somebody on the arm, whatever, or you have somebody that was in a fist fight that has cut up their hand on somebody else's teeth. The mouth is a pretty dirty place, a lot of pathogens go in there. In human, group A strep, E. carotids, staph, animal Pasteurella species, staph and strep. Cats are the worst with bites because they got these long canine, I guess they're not canines because it's a cat, but whatever, long teeth, and that just further implants that bacteria further and further into the subcutaneous tissue and provides more incidence of infection. Treatment is debridement, extensive washout, loose closure if the laceration is bad. Antibiotics, Augmentin works well for both human and animal. Augmentin is pretty much your go-to bite of the extremity. Antibiotic works well on the pathogens associated with it. Loose closure if a laceration is bad. And that's important after you do your washout from an animal bite, dog bite, cat bite, human bite if it's bad enough. Wash them out, clean them out really well, normal saline, chlorhexidine, things like that. But you don't typically want to do a primary closure on these types of injuries, because what you're doing is you're closing the bacteria that's left inside there and making a pocket for it to abscess and grow. So a lot of these things, you just want it to just kind of leave it open. If it's in a non-cosmetic spot, you know, like it's not on your face or eyebrows or mouth or anything like that, I usually just let them go, unless there's just, you know, a huge amount of skin just filleted everywhere, and then you just kind of want to slightly tack it together a few paces to give the skin some integrity, but also leaving some openings to let the wound kind of fester out, and also where you can clean it with soap and water can get down in there too. So don't ever truly do a complete primary closure of animal or human bites on a laceration. If it's something on the face and their face is all jacked up, and it's from an animal bite, then I'm usually referring those to a plastic surgeon or something like that that can get all that stuff figured out. But if it's on the extremities or wherever, just do some loose closure. They're going to have a scar there. You know, sorry you got attacked by a pit bull. I can't control that. But you don't want them to. You don't want to close that up and seed it for infection. All right. Paronychia has inflammation infection involving proximal fingernail folds. It could be erythema, maybe a superficial abscess formation. Warm compresses, oral antibiotics, Keflex is good. Topical really doesn't work very well, doesn't really get inside that area. If it's an abscess, you can IND it, you can see the paronychia there. So that's got a nice little abscess and pustular fluid collection here. Numb it up, do a digital block, just do a single slice right down the middle of it, drain all that crap out of there, put them on a little antibiotics if you want to, and that stuff will clear up pretty good. Paronychia, felon, kind of the same thing. See those all the time. Infected tenosynovitis, so flexor tenosynovitis is an infection split along the flexor tendon sheaths. Pulleys, the A1, A2, A3 pulleys that we talked about facilitate the spread of infection, and thus the extensor tenosynovitis is usually uncommon. It's going to be more of your flexor tendons, the infective tenosynovitis, rather than extension. Rarely get that. Infection can cause necrosis and possible compartment syndrome. Mechanisms can be traumatic implantation, so a puncture wound, or a hematogenous spread, gonorrhea and mycobacteria. Sometimes you can have a hematogenous spread. Most of the times I found this to be puncture wound. Some, old guy was working on a trailer or out doing some metal work, and some, cut his hand, poked his hand, and then now like 4 or 5 days later, got a big swollen hand. So it's going to be tenderness along the course of the flexor sheath. The finger is going to be slightly flexed. This one is going to be pain with passive tendon. You guys know that one, tendon extension. Now obviously that's capitalized for a reason, because I capitalize things in my PowerPoint that I find important. That's going to be one of your main determining factors, because a lot of these things are difficult to differentiate from just your general tendon injury or tendinopathies or inflammation. This is one's going to be pain with passive tendon extension. So people can have pain with movement, things like that, or if you're doing forceful, putting a little force on that tendon and it hurts. This ones are going to be held in extension, and even just that right there will send these people off the roof. Any kind of passive extension along that tendon sheath is pretty indicative of the tenosynovitis. And this isn't something you just want to well, we'll put you on some antibiotics and send you to a surgeon in a couple of weeks. This is something that I'm more than likely, depending on the severity of it, calling a hand surgeon and saying, hey, I got this. Do you want to, bring him in the hospital and do it tomorrow, or do you want to, have him follow up in your clinic the next day and schedule him for surgery type thing? It goes back and forth between what I've had him do. I've had him put him in the hospital and do surgery the next morning. I've had him, say follow up in a couple of days after some antibiotics, whatever. But Suffice to say, if you're not a hand surgeon, that you're calling them and getting their, so treatment's gonna be surgical debridement and IV antibiotic. Bank plus Cipro or Rocephin are good for the pathogens typically associated. It's gonna be a strep and staphylococcal species on that. So the 4 Conneville signs, so you have the sausage digit, uniform swelling along the entire finger, held in passive flexion, pain to percussion, palpation of the tendon sheath, and then pain of passive extension. So these again are just some signs that are associated with flexor tendinosynovitis. And I mean, I would hope that you would see a hand that looks like that, like, oh, that does not look good. He's almost got, I mean, that infection's bad enough that he's got desquamation of his skin here. Looks like he's got some skin breakdown. That may be the origin of the infection here. But you can see how this redness and streaking is going down into that flexor tendon, that pulley system that kind of goes down right through here. And you can see how obviously that hand right there, this is kind of a straight down image, but it's curved a little bit, held in this flexion, and obviously right here is held in pretty good flexion too. Any questions over flexor tendinosynovitis? All right, compartment syndrome, I think this is the last one we have. Increased pressure within the muscle compartment that leads to cellular anoxia and necrosis of the tissue. Mechanism, typically long bone fractures. Tibia is the most common area, so the calf is going to be the most common area of compartment syndrome. Forearm bones, second most common, especially for supracondylar fracture in children. You guys talk more about that whenever somebody talks about the upper extremity injuries. Trauma without fractures, crush injuries, thermal burns, penetrating trauma, etc. can also cause compartment syndrome. Non-traumatic thrombosis, bleeding disorders, IV drug abuse, if you get a lot of infection within a compartment. And you guys know about the compartments within the leg and the arm, about how that fascia is very thick, and you can imagine that once pressure gets inside that area, there's not a lot of give, and you can build up a lot of pressure in the area, and that pressure becomes so great that you eventually cut off blood supply to the area and it dies, and then you have nerve damage also with that as well. Some of your additional symptoms: pain out of proportion to injury, persistent deep ache or burning pain, paresthesia, suggestive of ischemic nerve dysfunction. When you start having some paresthesia in that area. Pain out of proportion to injury is pretty indicative, so you have somebody that you wouldn't think would be 10 out of 10 pain. So this compartment syndrome is effectively acting as a infarction. So it's like having a heart attack, but of the muscles in your extremity. So you can think of the pain that's associated, you think of with heart attack, it's the same type of infarction, ischemic type pain that we're associated with the muscles too. So those are some early symptoms. Later signs can be tense compartment with wood-like feeling. It's going to be tight, very tight. Pallor from vascular insufficiency, and muscle weakness leading to paralysis. I mean, if you're getting to the point where they have paralysis secondary to compartment syndrome, I mean, that's been going on for a while, and you're in a bad situation where that nerve's already dead, muscle dying, and that's not a good thing. Measurement of compartment pressures is performed by a qualified surgeon. It kind of looks like this weird thing you stick in there, and it like measures, it's like a needle type thing that sticks in there and it measures the pressure. I've never done it, obviously, because surgeons are the ones who do it. That's not available in all locations, the equipment that measures it. For testing purposes, pressure greater than 25 millimeters of mercury equals no tissue perfusion. So you can think of 25 millimeters of mercury is really not that much pressure, but it's in such a confined space that even 25 millimeters of mercury will keep you from having tissue perfusion. Treatment is going to be a decompressive fasciotomy. So they'll go through and then cut down into the fascia of said compartment and release that pressure. And that's typically what it looks like. It's not very much fun to have. I mean, that's pretty typical decompressive fasciology. It looks like that one from, yeah, well, I guess that may be an operating room because he's draped in a sheet. Yeah, we'll take him to the operating room and then just slice and dice him, and that's what it looks like. I wanted to go over, so there's, in the notes pages, do I have the 6 Ps of compartment syndrome? My notes page sucks. I'll have to redo that and send it out. It's kind of a mnemonic to help remember compartment syndrome, 6 Ps. Pain, pallor, paresthesia, poikilothermia, which just means that it's cooled. I guess there's only five Ps. Pain, pallor, paresthesia, poikilothermia, and
Pulselessness.
pulselessness. Very good, thank you. Is it in there?
No, I
You
looked
just-
on Google. And there's a
Okay.
6th one. It says paresis.
Okay, there you go, 6, paresis. There was, so 6 Ps, look those up. I could just swore I put them in, I apologize for that. I should have put those in the notes page. I assume that I did. I mean, why do you need guest lectures when you have Google, right? I don't know why I'm up here. Anyways, yeah, so the 6 Ps, think about those. Remember, pulselessness, paralysis, and things like that are going to be late signs of compartment syndrome. Those early ones are going to be pain out of proportion and with paresthesia, not anesthesia. So 6 Ps of compartment syndrome. I'll have to add that to my lecture. I apologize about that. Okay. Any questions over any of that stuff? I mean, that's pretty much it. Any questions over any of this? Elbow hands, things like that. Well, I appreciate it. Thanks a lot, guys.
Thank you.